Welcome back. My name's Francis. I'm a first-year medical student at the University of Sydney. I've been learning about haematology lately, so I thought I'd tell you about an interesting disease called acute myeloid leukemia. AML, or acute myeloid leukemia, is a type of cancer that affects early myeloid lineage cells, resulting in an overproduction in the bone marrow. Whoa! Alright, that could be a touch too much for people that aren't already studying haematology, so I'm going to break it down for you. Almost all the cells in your body have a specialized function. It's what makes skin cells, brain cells, and these specialized cells, also called differentiated cells or mature cells, they don't tend to divide too much. Cells, a lot like humans, start off with the potential to become anything that they want to be. These are called stem cells, and they can undergo many divisions, unlike differentiated or mature cells. Stem cells divide, and one of the divided cells will begin to mature. Initially, it's still called an immature blast cell, but eventually, as it differentiates and takes on specialized functions, it's considered a mature or differentiated cell, and it will exist within a system of the body. Looking at the example of blood cells now. All your blood cells come from hematopoietic stem cells. These stem cells are located in your bone marrow. The first step after dividing off from one of these hematopoietic stem cells is to choose either the myeloid or the lymphoid pathway. Today we're concerned with the myeloid pathway. This produces things such as red blood cells, neutrophils, megakaryocytes, which make your platelets, and some other cells as well. Back to AML. The issue is that you get a buildup of all those blast cells, and this unfortunately impacts on all the other myeloid lineage cells too. Normally you should only have 1 to 2% of bone marrow cells being blasts, but acute myeloid leukemia is diagnosed when more than 20% of bone marrow cells are blasts. On to pathogenesis now. Simply put, the immature cell's DNA is mutated, affecting certain genes. The mutations causing AML tend to be those that stop myeloblasts differentiating. So they tend to just stay in the bone marrow, they don't differentiate, they proliferate more, and then they cause problems for the other cells around them. One example of AML is acute promyelocytic leukemia, which involves a translocation between chromosomes 15 and 17. This translocation results in stitching together parts of the PML gene and the RAR alpha gene. Unfortunately, this creates a fusion protein. Go figure, it's called the PML RAR alpha fusion protein. Normally, the target genes for RAR alpha are those that cause differentiation. In the case of the fusion protein PML RAR alpha, it recruits proteins to these DNA sequences, and these recruited proteins suppress the gene. This means that they can't be read, and the cell doesn't undergo differentiation. In APML, this mutation usually coincides with the FLT3 mutation. The FLT3 gene encodes for a receptor tyrosine kinase, which normally will signal for cell survival and proliferation, but only at the right times. In the case of the mutation, this signaling gets kicked into hyperdrive. Another specific example of AML involves translocations between chromosomes 8 and 21, or an inversion in chromosome 16. These result in disruption of the genes for transcription factors RUNX1 and CBFB, resulting in, unfortunately, no differentiation. Risk factors for leukemia involve ionizing radiation, such as radiotherapy and X-rays. Cytotoxic drugs, such as alkylating agents and benzene, can be retroviruses, although that's quite rare. Your genetics can be a risk factor if you're an identical twin of somebody with leukemia, or if you have Down syndrome. Some immunodeficient states, such as hypogammaglobulinemia, and also age. In the case of AML, the peak onset is 60 years old. On to clinical features now. Blasts accumulate and crowd in the bone marrow, which unfortunately causes problems for the surrounding cells. This hence results in bone marrow failure syndrome. The features include anemia, which presents with fatigue, pallor, shortness of breath, and cardiac failure. Neutropenia, which can present with mouth ulcers, among other things. Leukopenia, which can present with opportunistic infections and fever. And thrombocytopenia, which results in bleeding. This presents as petechiae, purpura, mucosal bleeding, sometimes deeper bleeding, such as a cerebral hemorrhage. All in all, basically pancytopenia. Other hematological features include bone pain, gum hyperplasia, leukostasis, lymphadenopathy, hepatosplenomegaly, weight loss, and disseminated intravascular coagulation, also known as DIC. On to investigations now. Karyotypic variances are noticeable in 90% of cases, if you're using high-res techniques. A full blood count should show anemia, a normal to high mean corpuscular volume, severe thrombocytopenia, neutropenia, and if you look, you might see myeloblasts in the peripheral blood, which you should never see. As for diagnosis, we've talked a little bit about this already. When you take a bone marrow biopsy, you should see that more than 20% of the bone marrow cells are blast cells. Normally this should only be maybe 1–2%. Additionally, if you can see hour rods in the cytoplasm of these cells, that tells you it's specifically a myeloblastic type of leukemia, such as AML. Bone marrow biopsies can be taken either from the sternum or more commonly from the iliac crest of the pelvic bone. These can be either an aspirate or a trophine. Finally, immunophenotyping, checking chromosome abnormalities, and doing molecular analysis, such as flow cytometry, can be used to figure out the specific type of leukemia, because there are hundreds. AML is just one of 4 large categories of leukemia. Finally, on to management, the last section today. All-trans retinoic acid and arsenic trioxide are both treatments for the chromosome translocation T15 to 17, which we talked about earlier, creates that fusion protein PML-RAR alpha. What a bugger. All-trans retinoic acid causes the dissociation of those recruited proteins that were suppressing the DNA, whereas arsenic, we're not sure how, but somehow causes the degradation of those proteins. Chemotherapy can be used to achieve remission. It does this by inhibiting division. Mostly, it affects rapidly dividing cells. Another form of management is targeted therapy, which can involve monoclonal antibodies. Essentially, it uses the immune system to attack the cancerous cells, or small molecule inhibitors. The second to last form of management I'm going to talk about today is stem cell bone marrow transplant. In severe AML, or when you've relapsed with AML, the approach is to completely obliterate the bone marrow with high-dose chemotherapy. Then, once it's all gone, which eliminates all of the cancerous cells, a transplant is given. In older patients, high-dose chemotherapy and hence stem cell transplants aren't an option. They just can't tolerate them. So palliation is used instead. This doesn't mean that they're not treated. They still get treatments to improve their quality of life. They still get low-dose chemotherapy. And actually, this can improve their longevity. Okay, so that's all I've got for you today. That's AML. If there was something you didn't understand, if you've got a correction, or if you want to recommend something for another video, please just leave a comment or feel free to send me an email. I look forward to it. Bye.